you know, I don't know. You hearing me good?
Yes, go ahead, Doc. Go
Yeah,
ahead.
so the ovaries produce several hormones. All
Mhm.
right, hormones are chemicals which is secreted into the bloodstream and travel around to a receptor. So it's like the hormone is like a key, is like the key, and the receptor is the lock to open the door so that certain things can happen inside the cell. And the eggs and the ovary also produce eggs. It is, I mean, when you're born, you have a fixed amount of egg follicles and you're losing them all the time until puberty, when the pituitary gland switch on the ovary, and then every month a woman by and large release one egg. Sometimes it can be more than one, but by and large it's one egg. So the function of the ovaries to produce hormones and to produce eggs. Now I was just looking at some figures for Trinidad. In 2018, it was said that the incidence of ovarian cancer is around approximately 12 per 100,000 in Trinidad. And that would make it third amongst all of the gynae cancers, because the cervix is first, the endometrium is second, and the ovary comes in third. So overall for women in Trinidad, it would be about the fifth one, because the breast is first and colorectal cancers are either second or third. It switch with cervical cancer from time to time. The problem is ovarian cancer, even though it is less frequent than the cervix and the endometrium, it is the most lethal one. The mortality rate is fairly high. So, like for instance, for the 12 people per 100,000, probably about 9 or 10 of them will eventually die from the ovarian cancer. So it is very serious. Now, people want to know what are the risk factors. And this cancer is not as straightforward as the cervix, where I could tell you that is HPV or a persistent HPV infection. Multiple things affect the ovary. All right. So last time I just spoke extempore right from my head. This time I needed to put down some notes, so I will glance at my notes as I go along.
Yeah.
So for ovary, there are many different types of ovarian cancers, and they all behave differently. The cancers that develop from the surface of the ovary are called epithelial tumors. Approximately 80 to 90% are called serous tumors. The rest are called mucinous tumors. Of the serous tumors, 80 to 90% are high-grade tumors. The rest are borderline tumors, low-grade tumors, clear cell, or endometrioid cancers. Cancers that develop from the eggs are called germ cell tumors. And cancers that develop from the stroma of the ovary are called sex-cord stromal tumors. Today, I will focus on the high-grade serous tumors, which are by far the most common types. So you see, the ovary is very complex. So we can't deal with ovarian cancers en bloc in just one program. But this is the one that we need to deal with the most. So the
Yes.
risk factors for epithelial ovarian cancers include increase in age. So the older you get, the higher the incidence. Family history. So there might be a familial tendency. So if you have, first degree and second degree relatives in your family who were diagnosed with ovarian cancer, your risk will definitely go up. Then the third thing is nulliparity. That means never being pregnant. All right. People who never get pregnant or never breastfeed have definitely a higher incidence of ovarian cancer and any of the estrogen sensitive cancers. Estrogen is the main female hormone, but estrogen is a two-edged sword. You need it to be healthy and to be female, but too much exposure to estrogen over a prolonged period of time increase the incidence of certain cancers. Breast cancer, endometrial cancer, ovarian cancer, fallopian tube cancer, peritoneal cancers, the rectum, the colon, all of those are estrogen sensitive cancers. So anything that increase your exposure to estrogen over your lifetime also increase your risk for all of these cancers. Now, if somebody never get pregnant, that is definitely, I put it number 3 after increasing age and family history. Number 4 would be early menarche. Menarche means when you start your period. So if you start your period at around 9 or 10, all right, you'd be at higher risk than somebody who start at 4 or 14 or 15, because you've been through more menstrual cycles. And the more menstrual cycle you go through is the more estrogen you're exposed to and the more ovulations you have had. There are some hypotheses as to what We're getting some feedback. There are several hypotheses as to what causes ovarian cancer, and incessant ovulation is one of them. So the longer you have having menstrual cycles, the more ovulation you will have, the more estrogen you'll be exposed to, so the higher your risk. So starting the period early is a risk factor. Having your menopause late, menopause meaning the last period. So say the average time for most Black people is between around 47 to 50. If you are one of those who go to 53, 54, 55, still having normal periods, that means you're still ovulating. So you have a prolonged period of ovulation and a more estrogen exposure. So that is another risk factor. For people who never breastfeed, I put that at number 6 because when you're pregnant, the dominant hormone is something called progesterone. And we know progesterone is a physiological antagonist of estrogen. So the more pregnancies is the less ovarian cancer, because the progesterone will nullify this tendency of estrogen to want to promote cancer. And then when you breastfeed, the dominant, every time the baby suckle, a reflex go to the brain, and the brain secrete a hormone called prolactin that come back to the breast and keep the lactation going. So the longer you breastfeed, the more the prolactin stay high, and prolactin is another antagonist of estrogen. So both the pregnancy and the breastfeeding protect against ovarian cancer. So never breastfeed, I put that as number 6 as a risk factor. Never using a combined oral contraceptive pill is another risk factor, because the pill will shut down the ovary. So the pill shut down the ovary and prevent ovulation. That is how it causes contraception. So by preventing the incessant ovulation, which traumatizes the surface of the ovary, and then that means every month the surface of the ovary have to heal, and you may have a mutation that don't cause the healing properly, which eventually can lead to cancer. So more ovulation, more ovarian cancers. So people who on the pill, it stop you from ovulating, hence the protection. Plus the follicle, the cells around the follicle are called Graafian follicle cells, and they are what produce estrogen to prime up the lining of the womb, which is the endometrium, in anticipation of pregnancy. So when you abort the follicles from developing, the Graafian follicle cells don't produce much estrogen. Hence, it will lower your exposure to estrogen. So when people going through the menstrual cycle, they have very high level of estrogen exposure. But when they're on the pill, they have a lower steady state of estrogen. And the pill also add progesterone, which we already said is an antagonist of the estrogen. So the pill give big time protection by several mechanisms. It reduce your estrogen exposure, it add progesterone, and it stop the trauma to the surface of the ovary. You were saying something?
Yeah, so just a question. As you talk about the pill, so you know some of the myths around the pill and what it could potentially harm you. So how will you address that? Are you seeing the
Just
increase?
like last time with the cervix, I said that the benefits of the pill are enormous in so many respects. So I would always be pro people using the pill. So as I just explained, if somebody, for whatever reason, don't want to have any children, and if they use the pill for a prolonged period of time, like say 10 years, their risk is very low, because 10 years of the pill would give you similar protection like about 5 or 6 pregnancies and breastfeeding. So that for that 10 years, you'd be in a low estrogen environment. You would not be ovulating. Ovulation means releasing the egg, and it have to traumatize the surface of the ovary for the egg to come out. So the pill stop that trauma, plus it reduce your estrogen. So the pill is one of the most powerful things that protect against ovarian cancer.
So if somebody doesn't want to take the pill, are there any type of food they can eat that would mimic the estrogen from the pill?
Short answer to
The
that
pill
is
is man-made.
no. The short answer is no. There is no food that can point to you to tell you to eat to reduce your risk. And the relationship between diet and ovarian cancer is very complex. I will try to explain it a little further on. So let's just finish off the risk factors. We just reach never using the pill. I put at number 7. And the last one, I would also throw in obesity. All right, so obesity, people who are obese or overweight have a higher risk for many reasons. But one of the reasons is that the fat cells can produce an estrogen named estrone. And that estrogen is a very pro-inflammatory estrogen. Anything that cause, apart from the pure estrogenic effect now, anything that cause chronic inflammation also increase the risk for ovarian cancer. And the fat cells produce a estrogen, which is pro-inflammatory. So obesity is definitely a factor. And this is a manifestation of something else called the metabolic syndrome. All right, so we have 8 of the risk factors. 3, 4, 5, 6, and 7 are, all equals an increased exposure to estrogen. That was the nulliparity, early menstruation, late menopause, never breastfeeding, never using the pill, and being obese. All of those increase your estrogen, hence increase your risk, because I said that estrogen is a big part of causing certain cancers, and the ovary is one of them. The last one, which is obesity, all right, that one works through several mechanisms. Chronic inflammation, as I just mentioned, increased exposure to insulin, and increased exposure to estrogen. All right, so the obese people have all of that. No, I don't want to, it might sound, this is a difficult topic, and I'll be jumping all over the place if I don't try to follow my notes. So let me try to stay with my notes, because right now, the inclination is to get into the metabolic syndrome, insulin resistance syndrome, polycystic ovary syndrome, and all of those tie in with increasing the risk. But let me talk some other things which are jotted down.
Okay, because I have some questions for you, but you can go ahead.
All right. Only about 5% of ovarian cancers can be linked to a genetic mutation, like everybody know here about BRCA1 and BRCA2. BRCA is just an acronym for a long name of some enzymes that are important to repair DNA damage. So just like who I said, the incessant ovulation and chronic inflammation, all of these can damage your DNA. And the BRCA1 and 2 are genes that code for certain enzymes that help to repair the DNA. If you have a mutation in these genes, that means you can't repair the DNA effectively. And those people, the break or the mutation in the DNA eventually can cause problems that lead to cancers in breast and ovary. Now, the BRCA1 mutation is thought to be associated about 40% of the cancers caused by this genetic predisposition. And the BRCA2 is responsible for about 20%. But all of the BRCA genes make up less than 10% of all of the ovarian cancers, probably just about 5%. So they are not major factors. Most of the ovarian cancers have nothing to do with a mutation in BRCA1 or 2. These are not the only mutations. There are many more mutations. But it will get very technical, and I don't want to get into it because it's not a medical audience. The age is the most important risk factor for high-grade serous tumors. That are the ones we're talking about, because young people can get germ cell tumors and some of the other things, them granulosa cell tumors, but those are topics by themselves. So for the high-grade serous tumors, which is the most common one, increase in age increase your risk. And that is mainly because as we grow older, the immune system wanes. So last time I said that after age 15 is a downhill for the rest of your life for the immune system. And all of us form cancer cells every day, but our immune system usually can target them and take out the cancers. As we grow older and the immune system wane, is an increased chance that the cancers could take root and survive. So older, like in the States, most of the cancers, over 50% of the cancers, like in the States, are in people over 65 years. And I'm fairly certain that the figures for Trinidad and the rest of the Caribbean will be similar. Okay. So, yeah. You want to ask a question now?
No? No, go ahead. As my
questions
are lined up, aligned to what you're talking about.
And then it works for the older people, because as I said a while ago, the immune system is weaker, and the cancers, most of this cancer, 80% of the time it presents as a high grade, no, as a late stage. So the grade, let me try to the grade mean you could have well differentiated or grade 1, or you could have moderately differentiated or grade 2, or poorly differentiated and grade 3. Those are the most aggressive ones. And the most of the cancers that develop in older people are the high-grade serous tumors. So they tend to be the most aggressive ones. And then this cancer don't have any early warning signs that you could look for. And there's no screening modality. Like last week, we talked about the pap smear and Villi and VIA and all kind of other things we could do to screen for cervical cancer. And there's also a vaccine for cervical cancer. There's no such screening modality which has been proven consistent and effective for ovarian cancer. They have been trying for a long time to look at that transvaginal ultrasound tied up with something called CA125, but it has not panned out to be effective. So you'll be doing a lot of screening, plenty screening, which won't make a difference at all to the amount of cancers diagnosed or the early stage in which the cancer is diagnosed to make a difference with the mortality.
So Doc, what I notice is often called a silent killer. And
yes.
What you're saying, what makes it difficult to detect is because technology has not yet advanced to identify it early.
Yes, we do have no screening modality. So all of the screening modalities tend to pick up things early, and the earlier we pick up things, the increased chance of cure. So like for the cervix, we have the pap smear and HPV testing. For the breast, we have mammogram and ultrasound and MRI and all those things. For the colon, we could check for occult blood in the stools, or we could do colonoscopy, or we could do virtual colonoscopy with the CT scan. We don't have anything like that for the ovary or the fallopian tube.
So you mentioned the BRCA1 and the BRCA2, but wouldn't that help somewhat to identify people who maybe
Yes, it would help, but as I said a while ago, only less than 10% of all of the ovarian cancers have anything to do with BRCA1. So in an ideal world, if money wasn't a problem, we could probably screen everybody to see if they have a BRCA1 or 2, and you have other things too, what they call HDR or HRD is homologous recombinant gene deficiency, and others too. But these things are very expensive. You can't even do them in Trinidad. You have to take blood or tissue from the cancer and send it abroad for at least 2 weeks before you get the result, and they're very expensive. So a screening test usually have to be somewhere simple and cheap, and that most people could get it, a mass thing. You can't use a screening modality very expensive that very few people will ever get.
Okay.
You follow me?
Yeah. So it
And
makes
then you see the BRCA one only apply to a small proportion, less than 10%, or probably more like 5% of the ovarian cancers.
Okay. So I guess the precaution is, well, it doesn't necessarily mean that it will avoid, but reduce the risk. Reduce, lose weight, insulin, avoid diabetes and things like that. So exercise and nutritional
all right, you're learning plenty.
It's very important to strengthen the immune system to help ward off in the event, this comes.
Yes, all of what you said here is true, but I like to say if every woman could have at least 3 children between 20 and 30 and breastfeed them, each one of them for a year or 2, the incidence of breast cancer would take a nosedive about 80%, and ovarian cancer will be just behind the breast, probably about 70.
Between 20 and 30 years old.
Yes. So you find during that decade of 20 to 30, if this could happen, they would be in a low estrogen environment because, as I said before, during pregnancy, the dominant hormone is progesterone, which is a physiological antagonist of estrogen. And if they breastfeed the children for, say, 2 years, so that means between the pregnancy and the breastfeeding, that would take up at least 3 years. And then you wean off that child, you might have 1 or 2 periods and get pregnant again for another 3 years. And you wean off that child, have a couple periods, get pregnant again for another 3 years. So we could abolish the whole decade at 20 to 30 from the incessant high levels of estrogen and the persistent incessant ovulation. Because during the pregnancy, you're not ovulating, so you're not traumatizing the surface of the ovary. And if people breastfeed on demand, they will not be ovulating either. Okay? So that alone would be a major prevention, more than dieting and exercise and all those things. And this is one of the cancers that smoking don't seem to increase the risk.
Okay.
So alcohol.
It seems as if we need to make sure the ovaries are doing what it was created for, because
of course.
because what the book mentions is that, you know, it's really about securing procreation and the, yeah, so I guess in other words, we need to put it to work. But
Yes,
more
but you
and more
know, the
people are
fertility
delaying
rate,
having children.
yeah,
More and more women are delaying having children or don't want to have children. Some
yeah.
people are freezing their eggs and decide to have children later on in their 40s. Many women are still fertile in their 50s. But what you're saying, if you take that fertility all the way, say, into your 50s, you're at a higher risk given the length of time you've been exposed.
Having menstrual cycles and ovulating. Yep.
But then isn't the pill, it consists of estrogen? You're saying to take the pill. So
Yeah, so the pill have a very low dose of estrogen. But when you take the pill, the pituitary gland see the hormones from the pill and believe like the ovary is overproducing. And it don't want the ovary to overproduce. So the pituitary gland will stop secreting something called the follicle stimulating hormone, which is what stimulate the ovaries for the follicles to develop, and the Graafian follicle cells produce the estrogen. So when somebody is on the pill, it might sound paradoxical, but they have much lower exposure to estrogen than when you're not on the pill. Because the amount of estrogen that the ovary produce when you're going through the menstrual cycle is many folds higher than the little estrogen that is in the pill.
but you're adding to it, or isn't that the case?
No. Follow what I'm saying. If you use the pill, especially these modern day pills, only have 20 micrograms of estrogen. They are low dose pill. That will cause a negative feedback on the pituitary gland, because the pituitary gland don't want the ovary to overproduce. So it's going to shut down the ovary by stop secreting the follicle stimulating hormone. And
Okay.
that is what causes the follicles to develop every month and produce high levels of estrogen. So when you're on the pill, you are at much lower exposure to estrogen, and each one of the pill also provide the antagonist progesterone.
Okay.
Get it?
Yep.
I don't know what happened. I'm feeling a little bit dizzy. I hope I can stay right through.
You sure? You want to take a break? You want to get some water?
No. Let's go on. Let's go on. It's probably a little dehydrated. When you get old, you don't drink enough,
The
and we can
family
get
nearby?
dehydrated.
The family nearby?
I am good. Let's just look. You mentioned about the diet. I wrote some notes about the diet because I know this was going to come up. Diet and environmental factors. There has been no consistent association of any particular diet with increased risk for high-grade serous tumors. However, a diet rich in sugars, which is what you alluded to, simple carbohydrates, low in quality proteins and fats, especially if combined with sedentary lifestyle, that means lack of exercise, will lead to chronic inflammation, insulin resistance, obesity, metabolic syndrome, infertility. And all of those things would be pro-cancer.
Okay.
You got that?
Yes.
Yes. So as you mentioned before, regular chronic exercise, keeping a normal body weight, avoid sugar. Anything sweet is not good. Make sure that we get enough sunlight, get enough sleep, and all things like that. Eat more protein as opposed to carbohydrates. Carbohydrates is the rice, flour, Irish potato, and sweet drink, and all them kind of things that eventually lead to the obesity if we're not having plenty physical activity. All of these things lead to an increased risk for ovarian cancer. So in terms of diet, it's not like I'm going to point, say this food or that food increase the risk, or this food, that food, or that food decrease the risk. It's a holistic overall thing that we should try to avoid all of the simple carbohydrates, which quickly, when you eat a big plate of rice and flour and Irish potato and bus up shot over there, a macaroni pie over there, and then drink it down with a red Solo, it is very pro-inflammatory. And that now you're sitting down, as I said last time, you're sleeping in air condition, you're driving in air condition, you come to the office, you go upstairs in the elevator in air condition, and you all day sit down in the office air condition, and then come back home and repeat the cycle day by day. You will because you're eating so much, you're taking in so many calories that you're not burning, the body will store it first in the liver as something called glycogen and your muscles. And after those stores are full, then it will start to store it in the fat cells. And when the fat cells grow to their maximum level and can't take any more glucose, when insulin come knocking for the fat cells to take some more glucose to convert to fat, the fat cells can't take it. That is what we call insulin resistance. So even though the insulin high, the fat cells not responding to it to take any more glucose, and eventually back up in the bloodstream, and that is what we call type 2 diabetes, which is an epidemic all over the world now and very rampant in Trinidad. So with respect to the diet and the environmental factors, all the things you mentioned before and what I just mentioned here are critically important. So all the things I just mentioned, all of them increase. The fat cells, especially around your bowel, is called visceral fat, and they produce some chemicals called cytokines, and the cytokines are the mediators of chronic inflammation. And then when you get fat, you increase your insulin because the insulin very high already from what I just explained. And then you also, because every time you eat sugar or rice or carbohydrate, the glucose is the stimulus for the pancreas to produce the insulin. And then people eating too often, every 2-3 hours they're eating. So, the insulin goes up when you eat sugar, rice or flour, Irish potato, and really should clear the glucose out of the bloodstream, put it into the cell for the metabolism of the cell, and return to normal by 2.5 hours. But by 2.5 hours, the person eat again. So they eat some chocolate or granola bar, or they eat a ripe banana, or some kind of muffin, or any of them sweet things. And so the insulin is constantly being stimulated. So the insulin is always high. And then, as I said to you a while ago, once you saturate the storage, which is the glycogen in the liver, glycogen in the muscle, and the fat cells grow to their maximum size and can't take any more because the glucose is converted to fat, can't take any more, then that is what causes insulin resistance. So even though the insulin is high, it can't move the glucose from the bloodstream because all of the tissues them saturated. And that is when the glucose back up in the bloodstream and start to damage everything. You follow me there? I'm not hearing you.
Yeah, so doc, yeah, thanks. I understand that. So okay, we take some of these lifestyle behaviors to hopefully mitigate the risk against getting the cancer sometime after. But when it comes to things like endometrius, fibroids, and so on, are they linked in any way to
All right.
ovarian cancer? And if women have those, should they be more vigilant?
Well, the endometriosis, that means when the lining inside the womb leave inside the womb and go outside. So any ectopic endometrial tissue is what we call endometriosis. If the lining of the womb got down into the muscle of the womb, they used to call that internal endometriosis, but nowadays that is called adenomyosis. And estrogen is what promotes all of these. Now, if people have bad endometriosis, it is estimated that about 1% of all of the ovarian cancers are called endometrioid, and most of those develop in somebody who had endometriosis. So endometriosis directly could increase the risk of ovarian cancer slightly. But a lot of people who have endometriosis, because of the chronic inflammation in the pelvis, it could also damage up the tubes. So endometriosis could be a cause of infertility. And if somebody is infertile, as we said before, they can't get pregnant and they can't breastfeed the children. So that's a secondary means in which endometriosis could increase your risk for ovarian cancer. So there's a direct risk and there is a secondary indirect risk if it causes infertility. You got that?
Yes.
Similarly, if you have bad fibroids, and fibroid is not a big cause of infertility, but if you have bad fibroids, all right, and for some reason those were associated with you being infertile, that could indirectly increase your risk too, because if the fibroids cause you never to get pregnant, then you won't get the protection of the pregnancy, and you get the protection of the breastfeeding either. You see what I'm saying there?
Okay, okay,
Yes. So they could indirectly be involved.
okay.
Let's not look. So we have been talking about the next topic I put here, headline was reproductive and hormonal factors, of which we have dealt with some of it already. But let me
Right.
just go through my notes a little. There are several hypotheses how this works. However, none of them will cover all situations. Number one, incessant ovulation, which I just mentioned before. Incessant ovulation hypothesis. We believe that there is an aberrant repair process to this surface epithelium following ovulation. Increased ovulation over a lifetime results in an increased risk of mutations that can lead to cancers. All right. In support of this hypothesis is the fact that, like eggs, laying eggs, which are forced to ovulate all the time, have a significantly higher incidence of ovarian and peritoneal cancers compared to eggs that are hens. These are chickens now that are not being forced to ovulate. Yeah. All right. So
Doc, I have a question for you. I don't know if you have those statistics.
Yeah.
But I'm coming back to, the whole issue of pregnancy, protecting you, being pregnant between 20, pregnancy and breastfeeding, because it's not just the pregnancy you're talking about. I'm learning a lot today. Pregnancy and breastfeeding protects you against these kinds of cancers, right?
Yes.
Do the numbers show that there's increase in ovarian cancer among women who have not had children before?
Yeah. Many studies have shown it, gone back a long time.
So why is that not more widely known? I just know that
it's widely known, it is widely known.
I've been here for
I've been talking about this for over 30 years. Anytime I'm ready on TV or anything, I'm talking. Everybody I see in my office, I get into this. What I'm saying to you here is
no,
that
I'm talking, it seems globally it isn't, because more women are moving towards, okay, I'm not 20 and 30, I'm gonna be perhaps building my life, don't have any kids. Later on, I have them. But
yes,
it
so the
seems to me if
decrease
more
in
women
fertility
know that,
rate,
maybe they would not make those decisions.
no, the decrease in fertility rate for whatever reason definitely correlate with the increased risk of all of the estrogen sensitive cancers. However, people could mitigate this if they go on the pill. So I'm plugging for the pill last time and I'm plugging for it this time also. So if somebody don't want to get pregnant, it is sensible to go on the pill because it shut down the ovary and reduce your estrogen, and that will protect you against breast cancer, ovary cancer, fallopian tube cancer, endometrial cancer, rectal cancer, colon cancer, peritoneal cancers. So I'm plugging for the pill, and I am not working for any of the pill companies. But this is well-known things. There's not any secret I'm talking here.
Yes. So ladies, hear that.
All right. So let me just finish this.
Yeah.
A while ago, I touched on the incessant ovulation hypothesis, and I explained why. But this and explain the corollary with the chickens that are forced to ovulate plenty to produce the egg. But this hypothesis failed to explain the increased risk of obesity and polycystic ovary syndrome, both of which results in a decreased frequency of ovulation. So the incessant ovulation, I think, can be the sole explanation for the increased risk, because these conditions, people who overweight and obese don't ovulate every month, and particularly if they have what is called the polycystic ovarian syndrome, which is tied up with the insulin resistance syndrome and the metabolic syndrome. So a lot of some of the girls them who have the polycystic ovarian syndrome don't have no period for years. That means they're not ovulating. So that should protect them. But the thing is, most people with the polycystic ovary syndrome eventually get overweight, they get obese, and then I told you the obesity increase the risk by increasing chronic inflammation via the cytokines, and also by increasing the production of an estrogen named estrone, which is very pro-inflammatory. I hope that was clear.
Yes, it's clear. I hope women are taking notes. I urge
right.
you online to invite other women you know on, because some of the doc is dropping some gems here for us.
All right. Another theory is the gonadotrophin hypothesis. Now, the gonadotrophins are chemicals from a part of the brain called the hypothalamus, and the hypothalamus control the pituitary gland. So the gonadotrophin might see the like GnRH. It means gonadotrophin releasing hormones, and they control the pituitary to secrete the follicle stimulating hormones or the luteinizing hormones. So any situation that increase gonadotrophin exposure seem to increase the risk. So, all right, under excess gonadotrophin releasing hormone stimulation, example, in those not ovulating, like in polycystic ovary syndrome. So people like who have the polycystic ovary syndrome, because they're not ovulating, the pituitary gland will putting out a lot of follicle stimulating hormone because the hypothalamus is stimulating it to do so with the gonadotrophins. All right. So those not ovulating, like in polycystic ovary syndrome, are the obese. This results in excessive estrogenic stimulation. The surface epithelium of the ovaries is entrapped in inclusion cysts, which persist and undergo malignant transformation. So that is the hypothesis. So I just mentioned that the incessant ovulation hypothesis don't explain infertility from obesity and polycystic ovary syndrome, why they should increase the ovarian cancer risk. Well, this other one here explains some of that risk.
Okay.
A third one is the androgen and progestogen hypothesis. Androgen means male hormone, and the main one is testosterone, and the main progestogen is progesterone. So the ovaries contain androgen receptors, elevated androgens, like in the polycystic ovary syndrome, because the polycystic ovaries secrete excess amount of testosterone. That's why the people tend to want to form mustache and beard and get acne, and the pubic hair can come up to the navel like a man, and the clitoris many times can get bigger, which is called clitoromegaly, because the clitoris is the same embryologic origin as the glans penis, the head of the penis. So the increased testosterone from the polycystic ovaries, like it's trying to form a penis. So this kind of situation has been associated with an increased risk of ovarian cancer. So, and in the past, there was a drug called danazol that we used to use to treat endometriosis. So women who took danazol, it is a synthetic androgen, and they used to use it for endometriosis, and they had a 3.2-fold higher risk of developing ovarian cancer than those who took the GnRH agonist. So you could try to treat endometriosis by blocking the pituitary from stimulating from blocking the hypothalamus from stimulating the pituitary, which then stimulate the ovary. So you could block the production of estrogen from the ovary by doing that. Or you could use the danazol, which is a synthetic testosterone, to block the estrogen receptors directly. But the danazol, being an androgen, had a big spike in over 3.2%. I didn't mean 3.2%, it's 3.2-fold. So over 300% higher incidence of ovarian cancer. So that is off the market now. I don't think you can get it again all over the world. I don't think it can be had again.
Okay.
All right. Then the progestins, of which the natural one is progesterone. But as I said before, all of the contraceptive pill, what we call the combined oral contraceptive pill, have a progesterone in it. Progestins are protective. Ovaries contain progesterone receptors, and the progestin levels are increased during pregnancy, and this is one of the reasons why the pregnancy protect, are in people who used to have some contraceptive pill called progesterone only pill. We can't get them in Trinidad again. But if somebody don't want to get pregnant or want to show they not get pregnant while they're breastfeeding, these were the pills to use because they don't shut down the breast. If you use the combined oral contraceptive, those is the ones that have estrogen and progesterone. They will stop the lactation and shut down the breast prematurely. So the progesterone only pills you can still breastfeed. And when we used to use, they know that these pills, because they had in progesterone, they suppress ovulation. They don't suppress ovulation, right? Not like the combined oral contraceptive. So it don't protect by preventing the trauma to the surface of the ovary. Just by chemically being there, it antagonizes the estrogen, and that lead to protection against developing ovarian cancer. I hope that was not too confusing.
No, and okay.
If you following, I hope that everybody is following.
Well, I hope they are too. Well, we'll have the recording later on for people to go back through. So
All right.
yeah.
So the progesterone only pill or even the injection. Some people like to use the Depo-Provera injection for contraception. So you get one of that every 90 days, right? It is a progesterone, and that progesterone will protect against all of the estrogen sensitive cancers or anything that estrogen promote, like breast cysts, ovarian cysts, endometriosis, adenomyosis, fibroids, all of those things. If you take the progesterone injection, you get protection against it, because the progesterone antagonize the effects of the estrogen.
Okay, so Natasha had that question. What about injection? So Natasha, I hope that answers your question. Someone had a question about when you get pain on your right lower back, what causes that but painful? I'm not sure what they're asking. But they're asking
I'm
from
not sure that all kind of things
about
could
pain in
cause.
their back. And
Many
someone's
things could
asking
cause
about
it.
somebody's asking about tubal ligation. I'm not sure what they're asking either.
Yes, so that some people might use the tubal ligation. That is
Mhm.
when you tie the tubes after you finish with your childbearing thing. And
Okay.
that is something else again that protect against developing ovarian and fallopian tube cancer. And we
Mhm.
don't know exactly why it does it. There are some theories that when you tie to the tubal ligation, it can remove parts of the thing, or you might clip it with something called a filthy clip, or you might put a ring over the tube to block it, called a fallopian ring. All of those, once you ligate the fallopian tube, there is a protective effect against causing ovarian cancer. It is believed that somehow it might interfere with the blood supply, or might cause some changes in the hormonal profile that will cause protection. But no one is really sure. It's an observation, and we don't really sure how it works.
Okay.
Yeah. So let's just go to the fourth theory, the inflammation hypothesis. And I mentioned it several times already. Endometriosis is a chronic inflammatory state. I can't see your face. Some numbers come up, November calendar come up. I don't know why that come up. And blocking your face. Yeah.
Where is that? On your site?
On my screen, yeah.
Yeah, maybe you need to call one of your in-house technology experts.
So the inflammatory hypothesis, endometriosis and PID. PID means pelvic inflammatory disease. So if somebody get a sexually transmitted infection, chlamydia, gonorrhea, syphilis, whatever, and it cause a chronic infection in the pelvis, right? Apart that directly, that chronic inflammation there could increase your risk, and it could directly, and it could also indirectly increase the risk, because both the endometriosis and the PID that could damage the tubes could cause you to have infertility. And if you're not fertile, you can't get pregnant, you can't breastfeed. All of this add up to an increased risk. So endometriosis and PID increase the risk of ovarian cancer. Endometriosis is particularly associated with endometrioid, which we're not talking about today, and clear cell cancers. Those are some of the rarer types. So the endometriosis is not so much associated with the high-grade serous tumors that we're talking about today, but with some of the rarer types. All right. It is believed that any cause of chronic inflammation increase the risk. All right. So there is epidemiological data that suggests that the use of NSAIDs, those are non-steroidal anti-inflammatory drugs like aspirin or ibuprofen or any one of those things, may protect against the development of ovarian cancer. Now, I don't want people to rush go out and taking an NSAID every day, because there are problems with that. They could cause pain from your stomach. It could cause problem with your kidney. It could also stimulate bronchospasm and bring on asthma, all those kind of things. But probably, I don't know, I've not seen it. I checked a mini aspirin a day, we know will protect against, will facilitate and protect against cardiovascular disease, like decrease your risk for heart attacks and strokes and things like that. And probably even pulmonary embolus. So probably sometime it might show that that might be having some protective effect. However, people might believe I'm tunnel vision and always coming back to like cancer, to cannabis. So I said here, nota bene, that is Latin for note well. I wonder if cannabis is protective, as it's a more powerful anti-inflammatory agent than the NSAIDs or even the steroids. You understand what I just said?
Okay, the cannabis, okay.
Yes. So especially people who using the cannabis oil, not smoking, because the smoking destroy most of the medicine in the thing. But if you extract the thing with a fat like coconut oil and you're using that, like last time we mentioned, that is very helpful for people to enhance sleep, also to deal with pain, chronic pain from joints, osteoarthritis, rheumatoid arthritis, and many, many more things. It may even, I haven't seen this yet, but a lot of things that cannabis may be doing, we don't know yet, because they're demonized the thing for the last 100 years and like ban it for the last 50 years, put it in the highest risk category, along with cocaine and heroin and methamphetamine and those things. So people couldn't get to study it properly. Now we're coming out of that dark age. You might find that this is one more benefit of cannabis, because it is potent anti-inflammatory. And if ovarian cancer, and not just ovarian cancer, it seems like all cancers start off with a chronic inflammatory situation. That's why the metabolic syndrome and insulin resistance syndrome are so crucial for people to do the things them to stop that. Like, for instance, reduce the simple carbohydrates, reduce sweet drinks, any kind of juice or sweet and thing is not good. You have to have regular chronic exercise. Try to maintain a normal body mass index. All of those things, along with food that can reduce inflammation, and a powerful effect would be intermittent fasting, or like I tell you the last time, I eat like once a day. So it's long, long hours I will go without eating. All of these things counteract the chronic inflammation. I don't have no plenty visceral fat. I hardly have subcutaneous fat. So I do have a set of visceral fat to pumping out a set of cytokines every day to be causing the chronic inflammation. So I hope that was clear.
Yes.
And that
So,
encouraging
Doc,
everybody to go and start smoke, because the smoking destroy most of the medicine. But I believe, I shouldn't say I believe, I try to think out things. The belief things sound like religion. And I'm not a religious person. But I believe it eventually will be shown. Now everything disappears. I don't know.
Is to ensure the human species is preserved, right? And it seems as if you have children earlier in life, between 20 and 30, it protects you against ovarian cancer and other cancers that are estrogen sensitive. So estrogen is one of the hormones that's secreted, in our bodies, right? So the proper functioning of the ovaries does require healthy physiological conditions such as physical health. So,
Am I hearing me?
hearing you, welcome back. Yay, Doc is back. Yep.
What just happened there a while ago?
I have no idea. This technology sometimes, misbehave. But I was
All right.
just doing a little recap about the ovaries and,
I just no, the last thing I touched on was the cannabis potentially as a
yes,
protective
we're talking about cannabis. So
inflammatory.
I don't know if I have a lot of weed heads here, but welcome back.
Okay. All right. It look like we never lose many people, if anybody. All right.
So probably about
Let me just touch. I've been touching on it right from the beginning, but let me just touch on it some more because it's so important. COC mean the combined oral contraceptive use. All right, so case control studies have consistently demonstrated that users of the combined oral contraceptive have up to a 60 to 70% reduction in the chance of developing ovarian cancer than do women who have never used the pill. So if people have used the pill, even for a short period of time, they get reduction. But especially, some studies show if you use the pill like consistent up to 10 years, you could get as much as 80% reduction, similar to the breast for the ovary. All right. The cancer and steroid hormone study that was called the CASH study, cancer and steroid hormone study, reported that the combined oral contraceptive used for even a few months reduced the risk by 40% for women between 20 to 54 years of age. The risk decreased more with longer duration of use. As I just said, 10 years go up to as much as 80%. This hypothesis failed to explain, all right, the decreased risk was substantially greater in the nulliparous compared to the parous women. So if somebody who never get pregnant use the pill, they get more protection than somebody who have been through pregnancies who use the pill afterwards. So if somebody, because the nulliparous person who never get pregnant, they are at very high risk. So if they use the pill, one study showed there's something called a relative risk was only 0.16. That means there's a reduction of 84% in the risk of ovarian cancer versus the parous women who used the pill for the same time period. Their relative risk reduction was 0.85. That means 25%. You got that, Donna? Donna?
Yeah, yes, Doc, I got that. Yes,
Yes,
yes.
that is a critical thing. And there's a study
Right.
people go and check.
Could
All
you
right?
repeat that and break it down in layman terms for us like we're 5 years old? We go through that again.
No, it's a particular study that showed if a nulliparous, a woman who never been pregnant, use the pill, prolonged use, it reduced the risk of ovarian cancer estimated at 84%. If somebody who have had children and afterwards use the pill for a length of time, they get reduction too, but only about 25%.
Okay.
Yeah. So the ovulation would have gone now to use for people who have infertility, and you use things to help you to ovulate. All right. They used to believe that this ovulation, just like with the chickens, like a drug called clomiphene that you could use, is a estrogen. It look like estrogen, but it can stimulate. Let's not get into it. Clomiphene is something you can use to enhance ovulation. And they used to believe that by increasing the ovulation, you probably increase the risk of having ovarian cancer. However, it has never been borne out accurately. So more recent studies have found either a very weak association or no association between the infertility drugs.
Oh, this is the fertility treatment you're talking about here?
Yes, things to increase your ovulation, like clomiphene. They used to believe that, just like with the chickens, if you use drugs to cause the person to ovulate, produce more eggs, then it would possibly cause more trauma to the surface of the ovary and lead to more cancers. But that has not been borne out.
Okay.
So people who are doing IVF, and they might be giving them follicle stimulating hormones and then following them with ultrasound they call it follicle tracking to see the follicles. So when you have like about 10 mature follicles in each ovary, then under ultrasound guidance through the vagina, you could use a needle to collect the ovaries from the follicles. So the drugs, either clomiphene or follicle stimulating hormones, it don't increase your risk of having ovarian cancer. That is the present day belief or knowledge. The
Okay.
next thing I had was the tubal ligation, but somebody asked it already. But maybe just read through the notes I made. There is a strong association between tubal ligation and decreased incidence of ovarian cancer. The relative risk is 0.33. So when they say 0. Anything below 1 mean protection. Anything above 1 for relative risk mean increase the incident. So a relative risk of 0.33, that means a 67% reduction in the risk of ovarian cancer. You got that?
Yes, yes.
All right. All right. The mechanism for the protective effect is unclear, as I said before. if you take out the uterus and leave the ovaries, that also gives some protection, but the relative risk is less. The relative risk reduction there is 0.67. That means at least a 33% decreased risk of developing ovarian cancer if a woman take out the uterus. And as I said before, we don't know, but they believe it somehow interfere with the blood supply to the pelvis, and this probably somehow affect the hormonal milieu that could lead to it. Hopefully, we will find out the reason behind this in due course.
Okay.
I just want to touch on hormone replacement because people will be worried about that.
Right.
As you know, I'm very pro hormone replacement, and a lot of people out there suffering unnecessarily because the doctors them and also the patients afraid because they might go on the net and say that HRT associated increased risk for breast cancer and that cancer and that cancer. All right. So some studies have suggested an increased risk of ovarian cancer with HRT use. Some have not shown this. The increased risk is in those who are using hormone replacement over 5 years use. If you're under 5 years, they weren't finding any increased risk. All right. Because of the lack of association with the past risk. So say somebody used to use HRT in the past and then stop using it. The risk go away. So they are believing because of the lack of association with past risks, it has been suggested that the HRT stimulates the growth of pre-existing malignant cancers rather than increase the risk of malignant transformation. You got that? They are saying that the HRT may stimulate the growth of a cancer which was pre-existing rather than the HRT actually causing the cancer. You see what I said here? So in many of the studies, if you find that you're in a study and less than 5 years, there's an increased incident, like the Women's Health Initiative study, it was breast cancer they were looking at. So cancer not happen overnight. It's a long lead time, at least 10 years from initiation. So if you find you're in a study and the study had to be stopped because they're seeing the increased risk of breast cancer or ovary cancer in a short time period, the hormone replacement did not initiate the cancer. It probably just stimulates something that was pre-existing.
Okay.
All right.
And what are some of the things that the HRT release for women? You say women are suffering. What are they suffering from?
Hot flush, night sweats, decreased libido, decreased ability to concentrate, mood swings, dryness of the vagina. Some people get mental issues. They're afraid to come out of the house, agoraphobia, they can't function. And with the lack of estrogen, you have acceleration, a cardiovascular disease because the estrogen is protective of the endometrial lining. So for a multitude of reasons, it is a good thing for people to be on the hormones. All right. And just before I leave this, the increased risk appears to be mainly associated with ERT. ERT means estrogen replacement therapy. So HRT means estrogen and progesterone. So if people who have the womb, we know that you really shouldn't give them pure estrogen from long time, because if they're using it long term, it could stimulate a pre-cancer or even cancer in the womb. So only people who are hysterectomized will give pure estrogen. Right? Those who have the uterus, you should give them hormone replacement therapy, estrogen with progesterone, because we know the progesterone protect against causing increased cancer like in the uterus, and it seems the same thing apply for the ovary. So HRT, because of the progestin, appears to be neutral or very, very slight increased risk. That was clear?
Yes, yes.
And we lose some time, but I just want to touch on we touched on it already, but let me just reinforce this. The hereditary ovarian cancer. Only about 10% of invasive epithelial cancers are believed to be secondary to mutations of BRCA1 and BRCA2 genes. The BRCA genes function as tumor suppressors. Loss of function of both alleles is required for cancer formation. All I'm saying here, if you have the wild type, which is the normal gene, those are tumor suppressors. If for whatever reason you have a mutation in the gene you inherited from your mother and father, then your cancer, your body, your genes can't, they are handicapped in repairing the damage to the DNA that happen just from living. We have whole heap of things that affect we every day that can cause damage to the DNA. So the body always have to be repairing DNA. So if you have genes that cannot function properly to repair the DNA, then you're at higher risk. You follow that?
Yeah.
So people who have, like, for instance, say they have mutation on the two, BRCA1 and BRCA2, roughly 80% of those people will go on to get breast cancer, and it's believed as high as 40% could go on to get ovarian cancer. Now, we're not slaves to our genes. So even if you have these mutations, the other things we mentioned before, the exercise, the eating right, low carbohydrate things, all them things are called the epigenetics, above the genetics, and you could modify and nullify your risk. You understand that?
Okay, okay. Okay, I didn't know
All
what
right, or get the children out of the way quick and go up on the pill, or if you don't want to have anything, some people decide to cut off their breast, or just go on the pill directly, or take out the ovary, different things. However, there are things we could do, because it seems like all the mutations are down the line. The things that are really right up front in the initiation of cancer are more metabolic things rather than mutations. So is the chronic inflammation and the high insulin and you understand what I'm saying? And the high estrogen and all that kind of thing.
Yeah, yeah. The book here did say the physiological factors
Yeah,
are important.
yeah. All right. So the lifetime risk, as I mentioned before, if you have the BRCA1 mutation, is believed to be about 40% for ovarian cancer. If you have the BRCA2, it's about 20%. And if you have the both of them, it might be a little higher.
Okay. How easy is it to test for these? I've never had one of those done, those BRC.
All right, so you could check in your blood, and that will see if you have what they call a somatic mutation that you inherited from your parents, but it is not done in Trinidad. I don't think any labs here doing it, so you'd have to send it away, and it's quite expensive.
Oh, okay, okay.
And if you have a cancer, you could send the tissues, the cancer tissue itself, away, and they could check in that too, because the mutations and the damage in the cancer, you might have somebody who don't have the mutation, you didn't inherit it from your parents, but they found that about 5% of the cancers could have the mutation in it. So the cancer could have the mutation while your body don't have it. You understand what I'm saying?
Yeah, yeah.
So you don't have the increased risk for the other things them, but it in. And this is important information because there are certain medication that if you have this, you could use. So we haven't get around to even talk about diagnosis of ovarian cancer and how we manage ovarian cancer, because this is a very complicated topic. It can't be done in a 90-minute session.
Yeah, yeah. But if we can talk a little bit about the treatment, we have a few more minutes.
I would prefer answer the questions them if people had questions.
There's not much. You answered already those that came up.
All right.
Somebody's asking, what can you do to help circulation? I'm not sure what that means, Heather, when you say, oh, well, somebody asked, does the use of ginger, turmeric, and black pepper combined assist with the reduction of inflammation in the body?
Yeah, and it could also help with circulation.
Okay. So
Yeah.
Heather, and Siobhan, hope that answers your questions.
Yes, it does. Thanks.
Somebody explain how intermediate fasting works.
Well, if you, as I said before, if you grazing all day, you're eating every 2-3 hours, every 2-3 hours, and especially if you're eating sweet things. So you're eating biscuit, and you're eating donut, and you're eating chocolate, and granola bar, and you're sucking a Julie mango, and then you're eating a bright banana. All of them things, right? They have sucrose, and sucrose for the fruits, and the fruits, sucrose is 50% glucose, 50% fructose. Or if you're eating them pastry, flour all the time, you're getting this glucose within a short time period. Within 2 hours of eating a big plate of rice and macaroni pie and thing, it converts it to glucose. And that is the stimulus for the pancreas to produce insulin. So if you eating every 2 hours, the insulin go up, and once it clear the glucose out, mean put the glucose into the cell for the cell to use for its fuel as metabolism, and then the pancreas should come back to baseline. But before it come back to baseline, you eat again. So it's incessant, go up, and before it reach baseline, it go up again, and before it reach baseline, it go up again. So the insulin is high all the time. So when the insulin high all the time, and as I said, it's trying to put the storage of the glucose and like the fructose from the fruits, we can't burn fructose. So when you eat 10 Julie mango, the glucose can be used for fuel, but the fructose, which is 50% of it, goes straight to the liver and is converted to fat. So that's why you can have people having acute fatty liver. 50 years ago, it was only people who are alcoholic, drinking a set of alcohol, because we can't burn the alcohol and go to the liver, and the liver convert the alcohol into fat. And if that stays chronically, it eventually damages the liver and end up with liver cirrhosis and liver failure and death. So it might sound like I'm saying fruit's not good. What I'm saying is sweet fruit, too much, not good. You understand that?
You eat your fruits in season. I love my mangoes. I will eat a bowl.
Yeah, eat your fruit in season, but with moderation. Because you see,
exercise.
the table sugar is actually safer. Because the table sugar is just glucose.
Oh.
So when you eat the Julie mango and them is glucose and fructose. Are all them things that we're buying from Price Mart or coming from America. Everything have fructose corn syrup in it. Everything. All them cereal and all them things. And the fructose, we can't burn it as fuel. So the liver have to convert it to fat. And once you fill up the fat stores, liver in your muscle and the fat around your belly, which is called visceral fat, you're going to get inflammation, because the fat now will be secreting some things called cytokines. And those are pro-inflammation. There's a whole heap of them. Interleukin-1, interleukin-6, tumor necrosis factor. There's a whole host of them, right? We don't want to get into that because it's not a medical talk per se. But the more visceral fat you have is the more chronic inflammation. And the main thing that causes that is eating too much simple carbohydrates. And particularly if you're consuming fructose, because we can't burn fructose. I hope that is clear.
Yes.
Now, we said before that there is no screening modality for ovarian cancer. So most times when we diagnose ovarian cancer, it's already stage 3 or stage 4, which is late stage, because the cancer there 10 years and plus already. But it don't cause no sign and symptoms that will bring you in. And it is not, we have no screening modality. So most of the time when people pick up a cancer, like this aggressive cancer, serous, high-grade serous cyst, adenocarcinoma, is by accident. So somebody might go and get an ultrasound scan for something. Them have fibroids, or them have endometriosis, or they having some pelvic pain, or they think them have appendicitis or diverticulitis or something. I do ultrasound scan, and the ultrasound scan pick up the tumor. Or your belly start to distend. Because some of the cancers can produce a fluid called ascites that can fill up your belly. My record is 14 liters I drained from a lady over in Tobago once, right? So the cancer generate all these things. So our belly very distended, and the most of it was with fluid. Now, you can have a lot of disease in the pelvis and abdomen that distend it, and it look like you're pregnant when it's just the cancer and the fluid. So you could get vague ache and thing. These cancers don't cause no big set of pain, but if you're having, like bloating and when you eat, you're full quick, because you might have big mass inside there compressing the stomach and reduce the stomach capacity, or fluid there compressing the stomach and reduce the capacity to eat. So you're satisfied very, very quick and feel bloated all the time and have aches and them kind of things. And you present and we check, and it's an ovarian cancer. So those people, the first treatment should be proper surgery, especially if the person is stage 3 or 4. You have to go inside there and make a maximal effort to remove everything. The ideal is to take out everything that you leave back nothing that you can see. Sometimes people have what is called miliary disease. So you have thousands of small nodules. That operation will never done, you might bleed to death. So once you reduce things that you don't have anything bigger than a centimeter, that is considered optimal debulking, because the small volume disease is very sensitive to combination chemo. So this cancer, even though it's aggressive, it is a very chemosensitive cancer. So somebody who had adequate surgery up front, this kind of cancer should really, especially stage 3, stage 4, should be done, that surgery should be done by a gynecologist, because the general gynecologist's ability to optimally clear it is not good, right? So you have to be comfortable in dealing with the bowel, in dealing with urethra, and dealing with bladder. If necessary, out by the spleen loaded with cancer, I will take it out. If the momentum that is part of the immune system attached to the transverse colon loaded with cancer, and this is intimately attached to the bowel and thing, and so I will resect bowel and reanastomose primarily if there's not plenty of disease there. Or say, for instance, the pelvis full up of tumor, the rectum and the sigmoid and all them things full of tumor. I will take out the rectum and the sigmoid and do a descending colostomy. So when you do aggressive surgery like this and minimize any residual disease to a minimum, and within 4 weeks, you start hit them with combination with something called paclitaxel and carboplatin. The response rate is very good. Upwards of 80% of people will respond very good. Now, not all ovarian cancer produce a protein called CA125 that you could measure. But for those who have the CA125 elevated, it helps us to monitor the treatment after. It's not so important in diagnosis. But say somebody come in and they CA125 is 10,000 and you do the surgery, right? And then you start to give the chemo by 4 weeks after. After every 3 weeks, you want to give it, every 21 days. So after the third one, when they come for the fourth one, you'll check the CA125 again. And if the CA125 has normalized by after 3 cycles, that is telling you this tumor is very sensitive. So you give 3 more cycles, and then in the past, what we used to do is just observe now. All right. But ovarian cancer, stage 3 and stage 4, recur around 75 to 80% of the time. There's not many people you will cure that it never come back. So before you used to just have to wait and hope that if it recur, if the CA125 start to go up again, that it is after 6 months. If it's after 6 months, then you could use the same drugs again. If it starts to go up before 6 months, that is saying that the cancer has developed resistance to the chemo, and you're going to have to go to something second line. But that is not good, because the second line medication, anything you use, the response is like 20-25% as opposed to 80-85% in the primary treatment. No. So they were always looking for things for what we call maintenance therapy. So after you have your optimal surgery and get your 6 cycle of chemo, nowadays we have good drugs that could put you on that will prevent the cancer from coming back. Or if it can't prevent it from coming back, it prolong the time before you have a relapse. You getting that? I'm not hearing you.
Yes, I'm getting it.
Yes,
It's a lot.
getting that?
It's a lot, but we're getting it. Yes.
Yes. So there, let me just mention it. There are some drugs called PARP inhibitors. And though PARP is a big, PARP mean poly ADP ribose polymerase. Not nobody remember that. Those PARP inhibitors. So these now, different from the BRCA1, as I told you before, these are some genes that can help to repair DNA damage too. The BRCA1 help to repair double strand breaks, whereas the PARP enzyme repairs single strand breaks. So if you have somebody who respond well, you could put them on what is called PARP inhibitors for the cancer. So what it's doing, it inhibits the cancer cells from trying to repair the breaks that we induce with the chemotherapy. You with me?
Yes, yes.
Yes, so we induce the breaks of the DNA in the cancer cells with the chemotherapy. It can happen in normal cells too, but the normal cells have a better ability to repair as opposed to the cancer cell. So once you finish, and if you start a PARP inhibitor, you inhibit the cancer cells from repairing the DNA damage. And you prolong the time before you're going to have any relapse or even prevent it from coming back. The problem is, this is financial toxicity, because they're very, very expensive. And most people, even with insurance, won't be able to afford it. Two of them now available in Trinidad, and the cheaper one costs like $55,000 a month.
What?
And you need to use it for like 3 years minimum. The
Mm.
other one, which can be used for like 2 years minimum, costs like $58,000 a month. Now, apparently, the drug companies lobbying the government to see if they can bring them in. It would be nice if at some point these could be provided through the public sector, because it would make a big difference to the what we call the progression-free survival, and hopefully ultimately the overall survival from ovarian cancer.
Okay.
Because right now it is not good.
Wow. Are some ethnicities or ethnic groups or demographics more prone to being
It
diagnosed?
is believed, like in the States, that white people have a higher incidence over black people, but I don't know if that is a real genetic thing. It could be the amount of childbearing and breastfeeding and all them things confounding it. You understand me?
Yeah.
So if the average white person have one child and don't breastfeed them, and the average black person in America have 3 children and breastfeed them, that alone will make it look like the black people have a lower incidence or have some kind of protection.
Okay.
But it's not a genetic thing per se. Is the epigenetics.
Okay.
I hope that was clear.
Yes, yes. So
Now,
Doc,
it's a lot of things we talk about here
I
today.
know, yes, a lot to
Sorry
talk
we had that
about.
break.
We'll come back. We'll be back in another probably 2 weeks. So we'll be back for sure. It's a lot. I want to thank you for this information. We'll share it. Get the videos cleaned up and post it on YouTube so folks can access it. We're here to share information. This is not any profit thing between Doc and I. We just want to spread the love and share for more awareness. So that we can prevent the cost. Can you imagine $55,000 per month for some drug? Oh my gosh, I cannot imagine in
And
Jamaica.
that is in Trinidad. Everything in America much more
Yeah,
expensive.
much more expensive.
You're looking at 20,000 US a month in America.
Wow, that is amazing. So it's really important that we take care of ourselves, the physiological aspect of us. I know we talk about DNA, strange enough, 2 days, Friday and Saturday, I was at a session somewhere, and also Saturday, we're talking about DNA and how to repair DNA. It was more of a spiritual conversation, not religious, but many of us are not aware of our DNA makeup and what it means for us. So it's very important that we take care of ourselves from a physiological standpoint. And I think Doc, we don't touch on that a lot, but I think mental stress too leads to some of these physiological issues as
Yes,
well.
you see what happens.
Need to
If
give us
you have chronic stress, your
what is it?
body respond to it. What
Yeah,
them call fight or flight
right.
response.
Yes.
Yes. And you have a gland just on top of the kidney called the adrenal gland. It can produce a hormone named cortisol, which is a powerful steroid, what we call a glucocorticoid. And if that is elevated all the time because we're chronically stressed out, it will suppress the immune system. So the immune system can't recognize the cancer and can't take it out. So you
Okay.
have an increased risk for any cancer.
Right. So we hear about cortisol all the time. Now we see the connection. I didn't realize it was really impacting the immune system. I figured it was just you put on some weight when you have too much cortisol. Well, I guess that's part of it as well too.
It put on the weight because you see that now it causes it can make you become like you're diabetic, just like what I was saying before. So the
Okay.
fat stores and all of them get full up and all that kind of thing with the glucose, because we see, in order for you to fight or run away, you need plenty glucose. So you mobilize your glucose, right? So that your muscle can get the energy and your brain can get the energy, right? But that's supposed to be for a short time. So I see about 2 tigers running you down, and you might run in a cave and put a stone or something, or climb some tree where some rhino can't climb or something, right? But that's a short time period. But when it becomes chronic, that is day in, day out, week in, week out, month in, month out, then that is not good, because it's like you taking steroid injection. It will suppress your immune system.
Wow. Okay. So ladies, let us practice more self-care in terms of stress. Do not let work stress you, family, anybody else stress you. Try your best to manage your stress. and watch what we feed our bodies is very important. These organs, we don't see them, but our glands are so important. They are like the lifeblood of our system. So we need to make sure, that we are taking care of them. And Doc, I want to thank you from the bottom of my heart for spending time with us this Sunday. Got a little technical glitch there, but your info, people are writing, is very informative. And I like how you break it down for us layperson. And making people more aware. Sometimes you go to the doctors, they don't explain, they just give you stuff. Take this drug. Go
I
do
don't want to show up, but it's not many people can explain this or even know it. So what I'm saying, I'm not trash nobody, but most of your gynecologists out there don't know some of what I was saying.
Right. So ladies, take notes, ask questions, advocate for yourselves. That's also very important. We don't ask enough questions, we don't dig enough, and so on. We just go with the flow, right? So
And last week you asked about myths. So the biggest myth that I want to clear up here is that the pill not a dangerous bad thing for you by and large. And all of the risk factors you're hearing about, deep vein thrombosis and breast cancer and colon cancer and ovarian cancer and things like that, the benefits of the pill far, 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 far outweigh any downside.
Yes, that was very revealing for me. So we have women of all ages here, young, middle, and older. So
I just see Uriel Canterbury from Barbados came up saying thanks, boss. No, I will show my Uriel is one of my patients gone back about 18 years. She was sent down here from Barbados. She had a different cancer from this one, but it was advanced. And you hear what I say? I think it's about 18 years.
Oh.
After 5 years, that cancer usually never recur. So she said 17 plus, so she going to her 18 years.
Right.
Yeah.
Wow. That's a testimony in itself. Thanks for being here, Uriel. We're glad to have you. So ladies, take notes. We'll have this for those of you who have young women coming up, your daughters, your nieces, and so on. Speak to them. Don't be afraid of.
Kavita Maharaj is saying thank you, everyone. Kavita is one of the people that I'm hoping can do our stuff because she's one of the rep for one of the PARP inhibitors, something called olaparib. And if we can get that in the system, it will make a big difference.
So Kavita, well, I'll be reaching out to you. Send me a note, a DM if you can. We perhaps have a conversation as well. So thanks for being here. We're looking forward to having those, medications so people can, live a little bit longer and live quality. We want to live quality life. This is what this is about, right? And the more knowledge we have, knowledge is power. We live in the information age. There's no reason why we shouldn't know some of these things. Some of the things that Doc told me, I'm like, what? I didn't know these things. So again, Telsa Balwan, thank you for being here, Telsa. We'll have another conversation. Doc, I know perhaps we talk about autoimmune disease, perhaps want to talk a little bit about that. That is very pretty. I didn't realize that it's mainly women that are suffering from autoimmune disease. Men don't. I didn't realize.
The men have it too, but I know I saw you sent me. We can deal with that, but that is another big topic.
Yeah.
Yeah, it's a big topic. But you see, ovary, if we were to cover ovary fully, because we're talking today more about serous cis adenocarcinoma.
Right.
So the low-grade serous cis adenocarcinoma is like a complete different disease.
Okay, we'll have another conversation on that, right?
And then mucinous cis adenocarcinoma is like a complete different disease. Okay. Then when you leave the epithelial tumors and you go to things like the granulosa cell tumor, that should ring a bell. Yeah. And Tika cell tumors, those develop from this trauma is different disease. They behave differently, respond to different chemos, different things. Then you might have the germ cell tumors are mainly in children and adolescents, different disease. And they respond to different drugs, but they're very, very sensitive. So those are some that some of the ovarian cancer that can be cured, of high cure rate. Right. And then you have borderline disease. So you have benign cancers, borderline cancers, low malignant potential cancers. You understand? And high grade. So the ovary is about 20 different diseases. Yeah.
a really important organ. So I want to thank you again. We're going to wrap up here. Don't know if we have anybody who wants to ask one question. We give two persons a chance to ask a question. You can raise your hand, anybody, or you can unmute yourself and go ahead. Anybody has any questions for Doc or comment too, and then we can go.
I have a comment. Good afternoon,
Go
Bishop
ahead.
on. All right, so I just heard Doc say benign cancer, and I've never heard that. I always
No,
thought
no. If I said
it's
benign cancer, if I said benign, that's an oxymoron. I would actually mean to say a
okay, because I'm
benign
saying
tumor.
benign.
Thank
Oh,
you.
gotcha.
Yeah. If you say benign, you can't say benign and cancer in the same time.
Exactly.
Yeah.
That's why I was wondering what, you know. Thank you.
Yes, all right.
Anything else? Anybody else? All right. Well, have a good one. So now we know, have those children. Oh God, I don't want to say that because, you know, I don't want to, you know, leave it folks if they don't want to have kids alone, but just to say,
Yeah.
you know, let's protect you in the long run, right? So,
All right. So what we're talking about next time, you say?
Hmm?
What we're talking about next time?
I'll reach out to you. Maybe we continue this topic, or we could go the autoimmune route. I don't know.
We can talk about anything, you know, but we prefer to deal with the cancers.
Okay, yeah, all right. So we can probably continue with this topic,
Endometrial cancer.
uterine and stuff like that.
Yeah. All right. Cool.
So take care, everyone. Have a good night. This is Donna, bringing you, you know, conversations with Doc. My channel is called Glow and Grow with Donna. So we'll be talking about other things, not just medical stuff and stuff that, you know, not so pleasant. But you know, we're here to share and glow and grow. So bye, ladies and gentlemen. Thank you all for being here this afternoon. Doc, thanks a million. You know, it's a lot. You spend a lot of time with us, and I hope you're feeling a little bit better. So
Yeah,
take
man,
it.
me good. What's me hydrating? Me good.
Yes, I need to take a page out your book.
Yeah.
Bye. Thank you.
Bye, bye.
Bye, everyone. Those on Facebook, thank you for tuning in. And those here on Zoom, thanks for spending your time with us. Okay, take good care. We'll send the video out later on YouTube for you to revisit it.
All right.
Thank you.
Yeah.
Bye.
Yeah.